wabarakatuh. Dear colleagues, good evening. Let me first of all introduce myself. My name is Noura Qassimi, consultant ophthalmologist in medical retina and uveitis, the vice president of Emirates Society of Ophthalmology, which is known as ESO. On behalf of Emirates Society of Ophthalmology and in collaboration with Novartis, we are welcoming you in this evening's webinar. This webinar, it is having the title of A to Z in macular edema, which will review the basis in macular edema. Moreover, we'll focus on the latest updates in the investigation and management in different aspects in macular edema. This talk will be by our great scientific retinologists who are eminent in their field and dear to me in person. Let me introduce them to you. The first speaker will be Dr. Prasan Rao. He is a consultant ophthalmologist, vitreoretinal surgeon, and he is the medical director in Medicare Eye Center. Our second dear guest speaker is Professor Majdi Musa, who is a professor of ophthalmology and chairman of ophthalmology department in the Faculty of Medicine, Tanta University, Egypt. And our third great speaker and eminent retinologist is Dr. Ammar Safar. He is consultant ophthalmologist and vitreoretinal surgeon and the medical director at Morpheus Eye Hospital in Dubai. Welcome all of you. I thank you so much for Novartis and our great speakers to start this webinar. Now, regarding the question and answers. First of all, I would like to announce that there will be questions in the box that if you have any question, you can direct and type it directly. And if you have any certain question to a specific surgeon or retina specialist, so you can type his name so I can direct the question to him accordingly. So our first speaker is Professor Prasan Rao. The mic is all yours. Dr. Rao?
Yeah, thank you, Dr. Noura. I'm just sharing my slides. Are my slides seen now? Are my slides seen?
Yes. Yeah.
Thank you, Dr. Noura, and thank you, ESO. At the outset, I'm grateful to Novartis and Dr. Noura for giving me this opportunity to speak. I'll be talking on macular edema, new insights in definition and pathogenesis using ocular imaging. So this is the outline of my talk. What do we know about macular edema? Next, I'm going to review the anatomy of the retinal vasculature and how OCTA has helped us to understand the pathogenesis of macular edema. A brief talk on OCTA features of macular edema, and lastly, the role of AI-based technology to quantify fluid to measure disease activity and therapeutic efficacy. So what is macular edema? So the origin of the word edema comes from a Greek term known as edion, which later on was introduced as edema, and finally now we call it macular edema. So edema is spelled as O in UK and starting with the letter E in US. So by definition, macular edema is defined as the collection of fluid within and or under the retina in the macular region. So what do we know about macular edema? We know that the cystoid spaces are predominantly located in the inner nuclear layer and the Henle fiber layer. But however, some of these cysts might be present in the inner retina as well, particularly the ganglion cells, and in some patients may have subretinal fluid as well. We also know about the blood retinal barrier. The inner blood retinal barrier is formed by the vascular endothelial cells of the retinal vessels. And we know the role of VEGF and inflammatory cells, which are released and which cause altered vascular permeability and leakage from the inner blood retinal barrier. The outer blood retinal barrier is the RPE. We also know that edema in the retina is of two kinds. The vasogenic kind, where there is a compromise in the blood retinal barrier, and there's an extracellular edema. Most of the retinal vascular disease fall in this group. Cytotoxic edema is when the blood retinal barrier is intact. These patients have intracellular edema, and in some patients, or majority of these patients, the angiogram may not show a leak. These patients generally have a glial cell death. Common examples are drug-induced hyperviscosity syndromes or inherited diseases. So what information does angiogram give us? The fundus fluorescein angiogram gives us predominant information about the superficial capillary plexus. It doesn't give us information about the deeper plexus is in the retina. So it's a two-dimensional image of a three-dimensional structure of the retina. A bit about the histology of the retinal capillaries. We have 4 capillary networks present in the retina. The radial peripapillary capillaries, which are present in the optic nerve fiber layer. Then you have the superficial capillary plexus, which is present in the ganglion cell layer. The intermediate, and finally the deep capillary plexus. Now, the deep capillary plexus is present in the deep inner nuclear layer. So the inner nuclear layer has 2 capillaries on either side of its network. And the nomenclature basically suggests that we use the term superficial vascular complex for radial peripapillary capillaries and superficial vascular plexus, whereas the nomenclature of deep vascular plexus is used for the intermediate and the deep capillary plexuses. The retinal microvasculature in the perifoveal area is a layered vascular structure, and each of these layers have a distinct metabolic demand. This is how the superficial capillary plexus looks like on an OCTA. The capillaries have a complex 3D configuration, and they are more or less like the larger arterioles and venules, but they have reduced intercapillary spaces, and you see looping structures with vertical projections. I'll show you some images later which define this. This is the deep capillary plexus. If you look at the deep capillary plexus, it has a planar or laminar configuration, and important to note is they have these whorl-like arrangements in the OCTA. This is the schematic representation of the retinal capillaries, so of which the deep capillary plexus is the most important. I'm going to talk about this more in detail. These are organized by capillary units, centered by a collecting venule, and that's one of the reasons why you get the whorl-like appearance. The venous drainage of the entire retinal vasculature predominantly occurs through this layer. And it's also responsible for about 15 to 25% of the blood supply to the photoreceptor cells. So having understood this, let's try and see how the retinal fluid management occurs in the retina. So we need to understand what is the role of what are the routes of entry of fluid into the retina, what is the potential restrictions to the flow of fluid within the retina, and what is the mechanism by which the fluid is removed by the retina. So we know the concept of homeostasis. So we have fluid entry at one point to the vitreous and the vessels, and then we have fluid exit to the Muller cells and the RPE. So any imbalance in this leads to an edema. So the routes of the fluid entry into the macula would include the outer retinal border with the subretinal space, the inner retinal border with the vitreous, and the 2 vascular plexuses which I've already discussed about. Also, we need to note that the fluid is produced by the retina due to the glucose metabolism. So retina is a neural structure, so it depends a lot on glucose metabolism. This in turn produces a lot of fluid within the retina. So here you can see in a schematic representation the fluid from the vitreous, the superficial capillary plexus, the deep capillary plexus, the subretinal space, and this large cell here is the Muller cell, which I will talk about in the next few slides. The outer retinal border with the subretinal space is limited by the external limiting membrane. Now we need to understand the anatomy here because it is a junction between the outer portion of the Muller cells and the inner segment of the photoreceptor. I want you to bear in mind this concept. When the external limiting membrane is intact, the exudation from below the retina will just cause a serious retinal detachment. However, if there's a defect, the fluid from the retina goes into the outer retinal space, causing subretinal fluid. So the fluid movement within the retina is prevented by 2 natural barriers in the eye, which are the inner plexiform layers and the outer plexiform layers. So they do swell to a particular limit, but the main job is to actually prevent fluid spreading from one layer to the other. Now, how is the fluid removed from the retina? The main concept here is the concept of the Muller cell. The Muller cell or the retinal Muller ganglia are the cells which run across the entire length of the retina. This is one of the most important structure within the retina, which is responsible for the homeostasis, maintaining fluid, even neurological response, and the electrolyte imbalance within the retina. The Muller cell bodies are located in the outer plexiform layer, and it has 2 processes. The outer process extends, and as I mentioned to you, it forms the external limiting membrane in conjunction with the outer segments of the photoreceptor cells. Whereas the inner processes extend outwards and they form the footplates of which form the internal limiting membrane. So this is a structure which extends from external limiting membrane to the internal limiting membrane. Also, the Muller cell has a role acts as an optic fiber, allowing the pathway of light across the entire layer of the retina. So how does the Muller cell mediate hemostasis? Actually, it forms another layer of the inner blood retinal barrier in addition to the endothelial cell. So if you look at this Muller cell, it has processes which go on either side and engulf the superficial as well as the deep capillary plexus. And you can see these particular channels. I want you to remember the word aquaporin 4 channels, which are located at the inner limiting membrane, and these are responsible for transfer of water. These aquaporin cells, channels are also located around the superficial and the deep capillary plexus. So the Muller cell actually acts like a second layer, in turn modulating the amount and the composition of fluid which goes across the vessels here. So this is how the fluid goes in and out of the retina through the function of the Muller cell. So how does the Muller cell cause an exit of the water? The principal mechanism is known as potassium siphon. So again, this term is important, potassium siphon. So this occurs through a pathway which is known as the Kirk-4-1 pathway. So when the potassium leaves the through the Muller cell into the vascular plexus, in turn the water also leaves the aquaporin 4 pathway. So this mechanism of conjoint movement of the potassium and the water through the Muller cell into the capillary plexus is known as potassium siphon. We also need to remember that Muller cells also have an important role of using carbonic in terms of carbonic anhydrase mechanism. It has large amount of active carbonic anhydrase, and it is responsible for the regulation of the pH, carbon dioxide, and bicarbonate water transport. Traditionally, we would use carbonic anhydrase inhibitors with the aim that it has an impact on the carbonic anhydrase only in the RPE. But because of the carbonic anhydrase inhibition in the Muller cell, this role may play an important feature in certain types of CMEs, like in hereditary diseases where you use carbonic anhydrase inhibitors to reduce the macular edema. Now we need to understand what is the laminar nature of the retinal vascularity helpful for. So as I mentioned here, this is the superficial capillary plexus, this is the deep capillary plexus, and you have smaller vessels which go from one end to another, which are known as the capillaries. So the pressure in the blood vessels of both the superficial and the deep is governed by autoregulation. If you look at these capillaries in the superficial vessel, they're usually quite long as compared to the short vessels, capillaries which are present in the deep capillary plexus. So if you look at the Poisson's law, which looks at the flow rate, this is the pressure, this is the radius of the capillaries, this is the viscosity of the fluid, and this is the length of the capillary plexus. So if you assume that the blood pressure is constant between the two, the radius is constant between the two, of course the blood viscosity is going to be the same. The flow is inversely proportional to the length. So having said that, that means the resistance for the flow is least in the deep capillary plexus. So the majority of the blood flow actually gets drained to the deep capillary plexus. So you can see this arrow which indicates that the flow is mainly from superficial to deep, and then from there it gets drained out of the eye. So how does OCTA help us in explaining the mechanism of macular edema? So this is a colored view of the OCTA. This is the front view, which in blue you can see the superficial capillary plexus. And this is when the OCTA is viewed from behind. So you can see the deep capillary plexus in the red color. Note the difference in the size of the foveal avascular zone in the two different capillaries. The OCTA change in DME is very significant to note. This is a patient pre-treatment. You can see the large cystoid spaces which are shown in cyan color, and they are predominantly located at the level of the deep capillary plexus. And after treatment, you realize that once the cysts are gone, you can see a large area of capillary dropout. On the OCTA, there was a concept of whether these cysts are actually displacing the capillary plexus so that they are not visible, or is there an actual loss? So this clearly explains that following treatment, the fact that you are able to see a capillary non-perfusion indicates that there is an area where there is capillary dropout in the deep capillary plexus. Similar changes are also noted in the OCTA of CRVO patients. So pre-treatment, you have large cysts. Following treatment, when you look from the rear side, you can see corresponding areas of the capillary cysts, of the retinal cysts in the same location where you have capillary dropout. Also note that if there's recurrence, the recurrence occurs in the same areas where the patient had capillary dropouts in the deep capillary plexus. Similar changes you can see in the other retinal vascular diseases like radiation retinopathy and in MACTEL. What does this indicate? This indicates that the cystoid spaces occur predominantly in regions where there are dropout of capillaries in the deep capillary plexus. So once you have a deep capillary plexus dropout, like for example, there's no more perfusion in the deep capillary plexus. This leads to a state where there is ischemia because there is lack of flow in the deep capillary plexus. So there is localized area of ischemia. Because of this ischemia, you have release of VEGF cytokines, and there's leakage from the vessels which are perfusing in and around the area. Because of this leakage, there's increase in pressure. This eventually causes macular edema. It also causes overwhelming of the potassium and the aquaporin P4 channels, which I mentioned previously. And eventually what happens is the Muller cells will start enlarging and they eventually die. So once they die, if you remember, I told you the Muller cell is responsible for the external limiting membrane. There is a loss of integrity of the external limiting membrane, and then the fluid goes into the subretinal space and causes fluid there as well. Similarly, eventually you will have degeneration of the superficial capillary plexus, and this fluid then percolates to the superficial retina and causes damage to the superficial capillary plexus and the retina as well. So what is altered in the retinal vascular disease? So in diabetic patients, you have Muller cell swelling because of damage and swelling of these fluid collection within the layers, and eventually there is death of the Muller cells due to glutamate toxicity. So in short, the pathogenesis of macular edema is now shifted from just leakage to looking at capillary dropouts in the deep capillary plexus with reduced venous as well as the normal fluid drainage through the aquaporin channels. So remember the term potassium siphon. This eventually leads to ischemia, release of VEGF, finally leakage there. There's fluid overload, the Muller cells are overwhelmed, that causes macular edema, and then eventually there's Muller cell death. So you have subretinal fluid and the spread of the fluid in the superficial area. So having understood the pathogenesis, I'll have two slides on features of OCT, I'm sorry, there's a spelling mistake here. It has to be OCT in macular edema. So you see various kinds. We have subretinal fluid, interretinal fluid, cystoid spaces, vitreoretinal adhesions, microaneurysms, drill, outer retinal loss, and hyperreflective foci. So of which, if you look very carefully, there are some signs of chronicity of macular edema on OCT. The predominant feature is drill. Some of these patients might have cysts with hyperreflective membranes. You can have hyperreflective foci. Subretinal fluid is also an indicator of a chronicity of fluid. Eventually, there's disruption of the external limiting membrane. In my practice, I do see a lot of patients who have large confluent cysts like this, and especially seen on NFAS image, you don't see any septae between them, would also be an indication that these patients have chronic fluid. So my last talk is about the use of anti-VEGF and how the newer technologies have helped us to understand how the fluid management has occurred. So I'll be sharing a few of the slides which Dr. Ursula Smith presented to the RO meeting. This is a comparison of therapeutic response between brolucizumab and aflibercept in Hawk and Harrier trial using a deep learning based OCT analysis. So what are the recent advances in management of neovascular AMD? So we have therapies in the form of brolucizumab, which is a novel anti-VEGF molecule, and also technology. So we have AI technology or artificial intelligence technology based on deep learning methods, and together these is used to objectively assess the therapeutic response to anti-VEGF. So here you can see the fluid in various compartments of the macula, and the artificial intelligence is used to detect the amount of fluid present. So one slide about how Hawk and Harrier was performed. So this is the comparison of brolucizumab versus aflibercept. So in the brolucizumab arm, patients were given 3 injections, and at 16 weeks you had an assessment for disease activity, and based on disease activity, the patients were either categorized to Q8, that is the injection was given every 8 weeks, or 12 weeks for the rest of the period of up to 96 weeks. Whereas aflibercept was given on 3 monthly dosing, 3 doses, and followed by every 2 weeks as per the label. The OCTA images and the best corrected visual acuity were collected monthly at all visits. A large data set was now available from the Hawk and Harrier trial, which was analyzed by AI-based techniques to look at the following things: in intraretinal fluid, subretinal fluid, and the pigment epithelial detachment. So there were 1,812 patients, and there are almost 42,000 OCT images which could be analyzed. And a validated algorithm for fluid volume was used, which was through a fully automated detection and quantification of macular fluid using deep learning techniques. So this AI-based technology was used to detect the fluid in all compartments on pixel basis in the entire 3D volume. So this is a manual way of doing it. This is an automated way of doing the analysis. So let's look at the results of the analysis. So the analysis here on the top looks at the change of intraretinal fluid in the Hawk trial and in the Harrier trial. And I want you to remember that in Harrier trial, only 6 milligram of brolucizumab was used. This is the one which is being marketed as. So if you look at the graphs here, you can see this, the intraretinal fluid reduced by about 92 to 94% from baseline following the first injection in all groups. And this effect was seen throughout the macula. So at 1 millimeter, 3 millimeter scans, and at 6 millimeter scans, there was an extensive effect of this medication. And the intraretinal fluid mostly remained low throughout the entire maintenance period during the rest of the phase with both the medications. But if you look at the subretinal fluid resolution, this was superior with brolucizumab. Larger number of patients had more volume of baseline subretinal fluid. Nevertheless, subretinal fluid decreased by about 75 to 97% following the first injection. Brolucizumab treatment resulted in more intensive and stable reduction in subretinal fluid. So if you look at Harrier trial, which looked at 2 milligram of aflibercept and 6 milligram of brolucizumab, you can see the classic sawtooth appearance in all the 1 milligram, 1 millimeter, 3 millimeter, and the 6 millimeter scans, which are similarly seen in the Hawk trial as well. If you look at PED resolution was more pronounced as brolucizumab as compared to the aflibercept group. The PED volume decreased by about 70 to 80% of the baseline value with brolucizumab. This was stable and caused inactive lesions in the maintenance phase. This is clearly demonstrated both in the graphs of the Hawk as well as the Harrier trial. You can see the difference between the graph here and the size of the amount of fluid in both the groups. This is to look at agnostically the way we look at fluid in patients with neovascular AMD. And this is to look at the fluid and the relationship of the fluid during the maintenance phase with respect to the best corrected visual acuity. So what the authors did was they divided the patients into two groups, high disease activity group and the low disease activity group. High disease activity groups had larger or highest mean intraretinal, subretinal, and the pigment epithelial detachment volume, whereas the low remaining patients had lower levels. And what they did was, when you compared the vision of these patients in the Hawk trial and the Harrier trial, you can see that when these patients had lower levels of any fluid, they were associated with better visual outcomes. You can see here in the infraretinal fluid, the subretinal fluid, and the PED group. And when these patients had any residual subretinal fluid or PED, they were associated with a poorer visual outcome. This is again clearly demonstrated in the box plot here. So you can see that the highest eyes with the highest disease activity had very poor vision compared to the eyes with the lowest disease activity, which had almost 52% had very good vision. This is agnostic of whatever medication was used, indicating that fluid removal of absence of fluid is usually associated with better visual outcome. So I'll go show you two examples of this. This is a patient with high subretinal fluid volume during week 12 to 48. So this is between 12 to 48. You can see the mean volume of subretinal fluid is very high. And you can see also the vision has declined from 73 to 62 letters. Whereas from week 48 to week 96, the subretinal fluid has declined here. So you can see the amount of fluid here and here. And in turn, the visual acuity has improved. Another example of a patient with high PED volume during the maintenance phase. This is at 12 weeks, at 48 weeks, and at 96 weeks. You can see the volume of the pigment epithelial detachment has reduced marginally. However, if you look at the best corrected visual acuity, there's a significant drop over a period of 96 weeks in these patients. So lastly, to conclude, we learned about the role of inner and the outer blood retinal barrier. We looked at the role of Muller cells and how it helped to remove the fluid through the process of potassium siphoning using the two channels. It also acts as the additional barrier to the inner blood retinal barrier in conjunction with the superficial and the deep capillary plexus. Deep capillary plexus is the major retinal drainage site, and ischemia in the deep capillary plexus leads to an overload, Muller cell damage, eventually causing cysts. We looked at AI-based studies which showed us that there were low levels of intraretinal, subretinal PED during the maintenance phase, and these are independent and associated with best corrected, better visual acuity. And AI tools can automatically quantify fluid to measure disease activity and therapeutic efficacy. Thank you for your patient hearing.
Thank you, Dr. Prasan Rao, for your great talk. And we are going to move now with Professor Majdi Musa. Professor Majdi, the mic is all yours.
You can see my screen now, right?
Yes, Prof. No,
and
not yet. I can see you, but yeah.
Not yet? Are you sure?
Yeah.
I will share my screen now. Now we can see it, right?
We can see your, yes. Yes.
Thank you, Dr. Noura, for the invitation. Thanks, Nawaz, for inviting me, and thanks, Dr. Rabu, for your nice presentation. It's a lot of knowledge, and some of them are, not really new, but it's like a collection of a very good data to understand what is going on in macular edema. My part of the presentation today is management of neovascular AMD, and we all know that neovascular AMD had a lot of fluid inside. That's why I call it the fluid store. Let's clarify because I know there's a lot of ophthalmologists with us now, but let me classify which types we are going to speak about. Neovascular AMD can be classified into three main types. Type 1, as we can see, when the membrane is under the retinal pigment epithelium. That's why we call it subretinal, and it looks in the fluorescein angiography like late leakage of undetermined source. Type 2, where the neovascular membrane penetrates the retinal pigment epithelium and it appears under the retina. I'm sorry for that. And type 3, where the membrane starts inside the retina and then it goes down deep to touch the retinal pigment epithelium, and then it will be subretinal. So again, we have three types of neovascular AMD, and according to the anatomy, one of them under the RPE, one of them above the RPE, and one of them inside the retina, and then at the late stage, it goes down to the retina, to the level of RPE. In all these types, as we can see here, we can see that we have different types of fluid, which we will speak about in a minute. Before speaking about the fluid, let me give you a short insight in these slides about what is going on in neovascular AMD. First of all, diagnosis. The presence of fluid, like intraretinal, subretinal, or sub-RPE on OCT scan, are the diagnostic criteria of active neovascular AMD. Because sometimes we have a neovascular AMD without any activity, and this is the type we call intermediate, whereas we call silent CNV, whereas the CNV is there, we see it by OCTA, and there is no activity. And time to treat these patients. So visual outcome mainly depend on starting early treatment with the shorter time after the diagnosis. So the early we treat, the better the visual outcome. Then comes the disease activity, as we said, and it only depends on OCT. So in our clinical practice, fluid is an indication of active disease, and we see this fluid by OCT, and we follow it up by OCT. Yes, we do fluorescein angiography, but the main task is for OCT. Then the visual outcome. As we said, not only rapid treatment, but also rapid retreatment, because we have relapsing every now and then, and it's non-forgiving disease. Once it starts, you have to stick to the patient for his life. So rapid retreatment, again, will decrease the burden of the complication on neovascular AMD. And the last thing is how to treat. What are the treatment intervals? Once we start treatment, we have to have a protocol. We cannot treat the patient every now and then when he comes in. We have to have a protocol, and that's why we sit with the patient, we counsel the patient, and we tell the patient we are going to use this protocol or that protocol, which called PRN or treat and extend, as we will speak in a minute. Let's go to the fluid. As we know, we have three types of fluid in neovascular AMD. What we call intraretinal fluid, which it could be diffuse edema or spongy edema, or it could be cyst-like accumulation in a cystic pattern, and that's why we call it intraretinal cyst. And the second type fluid is the subretinal fluid, which is fluid under the retina, and mostly we see this type of fluid in type 1, where the retinal pigment epithelium is elevated and the fluid is reflected under the retina. And we have a third type, which is the sub-RP fluid. Why there is a fluid there? Because the membrane always starts there. So if the membrane is starting there and start to leak, it has to be accumulating under the retinal pigment epithelium. And even if it sticks to there, to type 1, or it comes to type 2, where it penetrates the retina, and then the fluid again will start under the retina. But let's have one thing in concern. All this fluid is considered pathological. None of this fluid is benign. They are all evidence of disease activity, even the one under the retinal pigment epithelium. This is the percentage of fluid component in one of the studies, the CAT study. They said that 82% is subretinal fluid. Most of the patients would have a tiny or a big amount of subretinal fluid, where the intraretinal fluid found in the majority of patients, 75%, and the sub-RP fluid, again, up to 50% of patients. So let's ask ourselves this question and try to get the answer. Does the intraretinal fluid have a negative impact on visual outcome in patients in vascular AMD? Definitely. It's the worst type of fluid, because intraretinal fluid accumulate in well-defined spaces, either cystic or in diffuse, or diffusely in the space as a spongy edema, and the presence of either intraretinal fluid or intraretinal cyst at baseline is associated with a negative impact on best-corrected visual acuity. Do we see sometimes patient with only subretinal fluid? Yes, I will present a case like this. But once we see intraretinal fluid, either spongy or cyst, we have to treat this patient as rapid as possible. And both residual and new intraretinal or fluid or cyst are also associated with worse visual outcome. So once we see the fluid coming back again after drying the macula, it's another bad impact on the final visual outcome. So we should not leave this fluid without treatment. How about the subretinal fluid? Does it have a negative impact? Definitely it has. But in some studies, they said that the presence of subretinal fluid at baseline and even residual of subretinal fluid were associated with either better or stable visual outcome, which is not that harmful for the retina as the intraretinal fluid. Other data suggest that recurrence of subretinal fluid during the maintenance phase could have a negative impact on visual function. Definitely any recurrence of any type of fluid, we consider activity. So if you dry up the macula and you find that the subretinal fluid is coming back again, it is activity. And we will see how to manage this. The last thing is the sub-RP fluid. This is very important issue. Our aim in treatment is not to flatten the retinal pigment epithelium, because sometimes it will never flatten. Why? Because the membrane is there. Either it's fibrosed or inactive. It is there. It will not vanish. So a build-up of fluid or blood between the RPE and the Bruch's membrane can lead to retinal pigment epithelium attachment, which we see it at the early phases of vascular AMD. And only small number of studies have investigated the importance of sub-RPE fluid in vascular AMD. But again, our aim is not to flatten the RPE. It will flatten, or not completely, but slightly, or even regress. But it is not our aim to flatten this. We should not keep injecting till the RPE is flat, because we all know it might not be completely flat. However, data suggests that changes in the sub-RPE space, if we treat the patient and the RPE is starting to flatten, not completely flatten, and again, we see accumulation of fluid or even hemorrhage under the RPE, it's a sign of recurrent activity. Our aim always in the management of AMD, like we see in this case, this is a case with a type 1, with the retinal pigment epithelium is elevated, with a fluid under the retina, fluid inside the retina. There is no cystic spaces, but our proactive treatment regimen, especially treat and extend, which I will highlight on, is most popular treatment regimen in neovascular AMD, and the goal is to dry up the macula. We keep injecting until the macula is completely dry, no intraretinal or subretinal fluid, and we regain the foveal contour. And this is our aim. And then after that, we start monitor the patient and do the treat and extend monitor. As we can see here, we are not flattening the retinal pigment epithelium, but at least it is getting lower. But again, the membrane will be there forever. So on the other hand, maintaining dry macula may lead to unnecessary injection. I would not go for minimal fluid sometimes and keep injecting to flatten this RPE and then turn the patient into geographic atrophy. What is the impact of any retinal fluid? All retinal fluid at the time of presentation is considered a disease, because when we look at the patient like this, we can see that it will affect the central foveal thickness or central subfield thickness, which we will count on in the follow-up of this patient. Because how would we know that the patient is improving? Yes, the fluid is going away, but we need to regain the foveal contour and go below 300 micron in the central subfield thickness. So it will affect this, and all retinal fluid will always be directly related to the central subfield thickness. So what's the importance of this? In the VIEW study, the patient with early persistent intraretinal fluid had significantly lower vision gain than those without early persistent intraretinal fluid. When we start treating the patient, or the patient is coming late and the persistent intraretinal fluid is there, the visual outcome, the end of the visual outcome is not that good. So the most important part is the intraretinal fluid. Keep your eye on the intraretinal fluid, either diffuse fluid or cyst. Again, in the CAT study, residual intraretinal fluid had worse visual acuity. If you keep treating the patient and you still see the intraretinal fluid, this patient visual prognosis is not that good, even at the 2-year follow-up. And at the VIEW study, a post-hoc analysis provides the further evidence that patients with residual subretinal fluid, residual intraretinal fluid, the vision will be worse than those with residual foveal subretinal fluid. So it means the intraretinal fluid again is the worst type to look for. Then came one of the studies which is called the fluid study. They tried to compare, giving ranibizumab, trying to compare if they can leave some amount of subretinal fluid compared with those patients who kept injecting until all the subretinal fluid is dry. We are not speaking about intraretinal, we are speaking about the subretinal fluid. And they call it 2 groups: zero tolerance, where there is no fluid at all, intraretinal or subretinal, to the relaxed group with some amount below 200 micron with subretinal fluid is there. And they compared both of them, and the study outcomes suggest that best corrected visual acuity improvement are similar in both groups. If they leave some amount of subretinal fluid, it is not harmful, instead of keeping injecting without extending and leading the patient to the geographic. So subretinal fluid may not entirely be an indication of ongoing neovascular disease, and it could be failure of pump sometimes, and it takes time with the treatment regimen. And this is the comparison: mean change in best corrected visual acuity at 12 and 24 months, and proportion of patients who gain 15 letter best corrected at 12 and 4 months. Both groups are almost equal. As we can see here, that even the patient with the relaxed arm achieved a comparable visual with less number of injections, which is significant. So it means I could spare some injection and I still keep the good visual outcome, as we can see here. Then let's go to the central subfield thickness variability, because this is very important. Increased retinal thickness and fluid on OCT in any space, as we said, is an indication of active disease. We look at the patient, we see subretinal or intraretinal fluid or sub-RP fluid, he's an active. And fluid resolution correlates with vision improvement, as we said. So can we tolerate fluctuation in retinal thickness? It is not that good point, because fluctuation means fluid is going, fluid is coming back rapidly. Fluid is going, fluid is coming back rapidly. This fluctuation will finally affect the visual outcome, and this is the CAT and EVAN investigated the association between fluctuation in central subfield thickness and the visual outcome. Again, the treatment agnostics approach, if anti-VEGF used in the intravitreal injection, they deliver a significant level of efficacy, and the data say here, if we keep fluctuating, the final visual outcome will not be that good. So we have to keep the retina dry most of the time. We should not leave any intraretinal fluid and the minimal amount of subretinal fluid, because fluctuation going back and forth will finally affect the photoreceptor and will affect the final visual outcome. Again, the pooled treatment data from the Hawk and Harrier and high central subfield thickness variability, comparing the Hawk and Harrier to the CAT and EVAN, they say again the central subfield thickness fluctuation had the worst visual acuity at the end. So this is the treatment guideline, the retreatment. Regarding the retreatment, once we see the patient with any amount of subretinal fluid or intraretinal fluid and it was not there, it means the patient is active. In the Royal College, again, intraretinal, subretinal, sub-RP fluid or hemorrhage, new ones are signs of recurrence, and OCT is the guideline in this monitoring. So let's go quickly through some examples to tell you what's the meaning of treat and extend and how we can keep the retina dry. First of all, let's ask ourselves a question. Why we consider our ultimate goal when we start treating patients with neovascular AMD? We can see many types of fluids, subretinal, sub-RPE, intraretinal. Of course, our goal is, if the patient is coming late, to stabilize. If he's coming early, to improve the vision and to maintain the dry macula by less injection and less frequent visits. This is our aim, to get the patient satisfied, rapidly rehabilitated, getting good vision and maintaining this good vision. Let me give you 3 or 4 examples of cases. Why we are moving or shifting to treat and extend? Because we used to treat PRN. PRN means, in the literature, 3 loading dose, 3 injections, and we look at the OCT. If he's dry, we stop injecting and get the patient in 1 month. And here's a patient coming very early with a very tiny CMV down there. We can see small amount of intraretinal fluid, tiny subretinal fluid, and sub-RP fluid. And after 3 monthly loading dose, the patient is completely dry. We can see a lot of drusen and drusenoid RP detachment, but we regain the foveal contour. There is no intraretinal fluid, minimal sub-RP fluid, but there is no subretinal fluid. And we regain the foveal contour and central foveal thickness went to normal. In these cases, we used to tell the patient in the old days, you are dry now, visit us in 1 month. We don't inject. You are completely dry, and I will monitor you after 1 month to do an OCT. But this patient came in 3 weeks, actually less than 3 weeks, about 18 days, with huge amount of fluid, even more than the first presentation. And he was, quite intelligent enough to notice the drop of vision, and he had a 636 vision, and this means recurrence. So he did not finish the months. Why is this? Sometimes we are not, even the loading dose is not good enough because we dried the macula, but the level of the VEGF is still high in there. So once you stop injection, the fluid comes back again. So it took me another 3 injections to dry up the macula because this fluid was higher than the first time, and the patient is going into macular atrophy. So that's why I used to do PRN. Now I shift to treat and extend. Let me rapidly give you a very nice case how to apply treat and extend. This is a male patient, and we can see he had a 56 years old. He had a type 1 CMV where the retinal pigment epithelium is elevated. There is a fluid under the retinal pigment epithelium, and the membrane is definitely there. And we can see a late leakage of undetermined source. And he had subretinal fluid and intraretinal fluid. Few tiny cysts, but most of the edema is the intraretinal edema, the spongy one. So we always start by 3 loading dose and then have a look at the patient. And sometimes even from 1 or 2 injections, you will get the macula dry like this. So if we get the macula dry like this, once you see this, you don't stop injection. Treat and extend mean you see him dry after the 3 loading dose, you inject. Even if he's dry, yes. But instead of telling the patient come every month, you can switch to every 6 weeks or every 2 months. So I switched to 8 weeks. So I told him, you will have another injection while you are dry, and then you come after 8 weeks. He came after 8 weeks. Still dry? Yes. So I will extend to 12 weeks. So it means that I am extending, but again, treating while the patient is dry, competing with the VEGF, not waiting for the fluid to come back. 3 months later, 12 weeks, he came back with the fluid. Yes, there is a subretinal fluid. And there is some kind of intraretinal fluid because you can see the thickness. So at this time, this is a recurrent. So we treat, but we shorten the period. We don't tell him, keep the same. No, we will shorten the period to 8 weeks instead of 12 weeks. So if he comes back in 8 weeks and he's dry, then we extend again. But again, we inject. We don't leave him without injection. Injecting the patient and telling him, come back in 12 weeks. Coming back in 12 weeks and he's dry, we can extend to 12 weeks, and then we can extend up to 16 weeks. Looking at this patient and telling if he's dry or not, sometimes I do OCTA to find that he had a dead tree appearance. There is no fluid, there is no activity. And what is this? I will speak about it in a minute. Sometimes we have, it's not a fluid, and I will explain this in a minute. How to treat and extend with residual fluid? Because I was not believing how we can leave fluid and tell that the patient will be or will behave good. So this is another patient with age-related macular degeneration. We can see this is a type 2 CMV. It's a classic one. We can see the intraretinal fluid and the subretinal fluid. And once we inject 3 loading dose, there is still activity because there is still intraretinal and mild subretinal fluid. And then again, after another injection, he had complete dryness of the intraretinal, but minimal subretinal fluid, as we can see. And at this moment, should I keep injecting to attack this? I regain the 260 micron. The macula is almost dry, minimal subretinal fluid, even maybe 20 or 30 micron, and 6/9 vision, and central subfield thickness is 266. Should I keep injecting this and not extending because I'm tracing this amount of fluid? I don't think so. So in this case, to trace the subretinal fluid, you shouldn't. You should inject and extend. And I did treat and extend, and the patient was stable, and I did treat and extend again, and the patient came back with this. This is a minimal amount of subretinal fluid, but this is coming with, it's below 200 micron, but with loss of one line and increased central subfield thickness. At this time, I should not monitor this. I should consider this subretinal fluid is a recurrence because of loss of vision. One line is quite good enough. and increase in the central subfield thickness, which we cannot afford. So it will affect the final visual outcome. So in this case, I will treat the patient and then shorten the period until I will get to the maximum visual acuity. I will get to the central subfield thickness to normal, and the patient, the blurring of vision will go away. Sometimes we have to treat and extend up to the minimal, even minimal subretinal fluid. Because in a case like this, look at this. This is the patient who is 65 years old, and he came with this. Once you look at this, there is something leaking here under the retinal pigment epithelium. And we can see flat and irregular RP detachment with overlying serous detachment. Why I say in this case, treat and extend with no allowance for subretinal fluid. Why? Because the only manifestation in this CMV is subretinal fluid. There is minimal intraretinal fluid, or almost there is no intraretinal fluid. The presentation is mainly subretinal fluid. So I should not keep any of this because this is the main presentation of the patient, subretinal fluid. Some patient might consider, some doctors might consider this is a tiny polyps down there and leaking inside the retina. So 3 intravitreal anti-VEGF and still the macula is getting completely dry. So I will not allow any fluid in this because this is the only presentation, only subretinal fluid. So I have to dry him completely. So we have to adjust our treatment modality. And again, we can see how it's active, how it's inactive, and at this time I can treat and extend, leaving no amount of subretinal fluid. My last case is the wet AMD. When to stop treatment? This is very important. This is a patient, one-eye patient. Look at the disciform scar and the surrounding RP atrophy. The whole macula and the paramacular area is destroyed in one eye, and the patient is coming even late in the other eye with 660 vision. And here is the presentation. Look at this. Subretinal fluid, intraretinal fluid, there is no much cyst, and we can see the subretinal hyperreflective material, which we call shrimp, and the subretinal fluid. I gave her a 3 loading dose. There is a minimal amount of fluid, but again, I injected her and I followed her up, and I look at this. Should I extend in this? This is the force injection, and I look at the foveal contour is regained. Some doctors will look at this, or some of my listeners will say, the audience will look at this. This is cyst. You should attack this cyst. This is again intraretinal fluid. No, it is not. If we look carefully, this is a degenerative cyst. Degenerative cyst, we should not aim to dry this because we regain the foveal contour. Second thing, look at the yellow arrows. These are outer retinal tubulations. So it's another bad prognostic factor, and meaning that we are having a dry macula with a rolling up of the photoreceptor. And I did OCTA to find out that there is no sign of activity, and it's a dead tree appearance. And this is very important not to keep injecting to attack this. So this is when we stop injection. We inject and extend, but we should not tell that this patient is still active. And again, treat and extend. So we will avoid unnecessary injection. We will not keep tracing this amount of fluid. And this is a very good example of outer retinal tubulation. It can happen in the paramacular area. And look at this. It's a huge outer retinal tubulation inside the fovea. So we will not mistake this as fluid. This is not fluid. This is a huge outer retinal tubulation. And this is a very bad prognostic sign. Risk of geographic atrophy with increased number of injection needed to dry the macula. As I said, we should not keep injecting while the macula is dry, aiming to dry completely the macula. I'm speaking about subretinal fluid, or looking at the degenerative cyst. Because in the CAT's analysis and CAT trial, they indicated that the eye treated monthly had a 59% risk of geographic atrophy at the end. Why? Because they have monthly injection. They didn't have PRN or treat and extend at that time. So it means that over-injection might end up in geographic atrophy, especially in recent study, type 3. When we have type 3, over-injection most probably will lead up to geographic atrophy. And this is the study I'm speaking to you about. The patient with type 3 and they have reticular drusen, they have the highest incidence of getting geographic atrophy. Put in mind that type 3 with reticular pseudodrusen is the worst type, and it will end up 50% of this patient with geographic atrophy. So my take-home message is most individualized treatment regimen aim to completely resolve all the intraretinal fluid and the subretinal fluid to achieve dry macula. This is our aim. Persistent intraretinal fluid is related to lower baseline when they start with, and delayed responders also they have a bad visual prognosis. It is possible, as I showed you, to allow minimal amount of subretinal fluid. It doesn't have to be 100, 150, 200 microns. It depends on your preference and your knowledge. And recurrence any type of fluid, if it was dry and this amount recur back, it means that the patient is active again because he's losing vision, he is complaining, and he had subretinal fluid. And final message is management of neovascular AMD is shifting towards personalized protocols. Treat and extend, but keep monitoring the patient, understanding what is going on, and the key is to treat, not how to try to achieve the best visual outcome. Thank you so much for your listening.
Thank you so much, Professor Majdi, for this wonderful talk and management, and one extra home message that keeping disregarding the fluid is an unforgiving attitude or concept in management. This is a take-home message for myself too. So we are reminding the audience that if there are any questions, there is a Q&A box, and we are happy to answer your questions at the end of the webinar. So then the third speaker is Dr. Ammar Safar. Welcome, Doctor, for your
yes. Thank you so much, Dr. Noura. First of all, I'd like to acknowledge everybody and then say good evening, everyone, and thank you, and thank the Emirates Society for the invitation. Also, thanks to Novartis for supporting this. Can you see my slide?
Yes, Doctor.
Okay, great. So, yeah, let me just put it on the slideshow 1 second here. Here we go. It's really hard to follow two very, very good speakers that presented such a wealth of information, but I'll try my best to make this useful, and hopefully we will have some sort of a discussion with the audience and with the panelists. So what I will be doing is presenting a couple of cases and trying to illustrate a couple of take-home messages, or potentially also learning from the panelists and from the participants who are attending this webinar, and improving our ability to provide care to our patients. So the first case I'm going to present is for a 67-year-old male who was referred to me for surgery in his right eye. So the referral basically said that the patient has been complaining of seeing a black spot in the center of his vision, and also mentioned that he has some blurry vision in the left eye, the other eye, for the past couple of months. His visual acuity in the right eye was 2200 and the left eye was 2100. Sorry, there's a typo here. So he has a past medical history of hypertension and no surgeries in the past. So looking at the retina in the right eye, the one that was referred to me, obviously there is a dense cataract that you can all appreciate here. But in addition to that, he also has a macular hole, a full thickness macular hole, as you can see here on the OCT. So this was the main reason for sending him to me as a VR surgeon, which we took care of. And I did a cataract and a vitrectomy in ILMP for the right eye, which closed the hole nicely and improves his vision. But I was nosy also and wanted to look at the other eye and see what is this about not being able to see in the other eye. So the vision in the left eye, if you recall, was 2100. And when you look over there, you can see that there is this picture of his left eye. Now, obviously, if you look at this, you go, this is potentially a central retinal vein occlusion. There is fluid in the optic nerve. There is fluid in the macula. Again, there is also a cataract there. And the red free, and this is the OCT picture. So this was taken 2 weeks prior to his presentation to me, and I had access to it because he was an internal referral. And as you can see here, that there is significant amount of intraretinal cysts along with the subretinal fluid, again, swelling of the optic nerve, and also there is some vitreomacular traction. So my question here at this point to pretty much everybody and to the panelists potentially, but we have a choices here that I've listed, A, B, C, D, and E. The first choice is whether you would do an anti-VEGF injection monthly for this patient in this left eye, whether you would do anti-VEGF PRN, steroid injections, vitrectomy, and other. So I guess right now, Dr. Noura, we can ask the audience to try and respond to that poll. We will give about 35 to 40 seconds to get this response. But if I may please get the panelists, Dr. Rao and Dr. Magdi, involved in this and see, maybe we start with our guest from Egypt and see, Dr. Magdi, how would you tackle this case, Magdi?
I will wait. I will speak for the 45 seconds until they vote because I don't want to influence them. But I will tell you my opinion. I will try to, not to stop talking until they influence. Look at the OCT. We will have a partial PVD, which is a thickened posterior hyaloid with a strong adhesion to the center of the fovea. And we have a cystoid edema and sensory detachment, as they said. This cystoid edema and sensory detachment, it's reflection for the central retinal vein occlusion, and this is an intraretinal fluid because of the leakage. But the point is, you have edema and vitreomacular traction. And this is not a vitreomacular adhesion because we always look at the interface because this is very crucial. Start treating this patient. This is a vitreomacular adhesion, and there is a sort of traction. We call this anteroposterior traction. We have to look at the adhesion. If it's a tiny adhesion without any strengthening in the posterior hyaloid, sometimes it's easy to separate this by intravitreal injection, mechanically, not because of the intravitreal injection. But if the adhesion is broad, and in these cases, I always like to look at different line scans, because sometimes if you check the other line scans, you might find a disaster. You might find an early partial thickness hole, or you might find a stronger adhesion or a broader adhesion in different line scans. So in these cases, I will never judge the patient with only one line scan. But in my opinion, this is a patient with a cystoid macular edema. Yes, secondary central retinal occlusion, but again, we have another element at the vitreal interface, which is a vitreomacular traction. So putting in your mind, treating the patient with a vitreomacular traction like this with cystoid macular edema, it's crucial to start injecting. I hope they finish the voting, because in my opinion, in this case, if you do surgery, it's the best chance for him, because injection in intravitreal anti-VEGF, I will never go through. But some patients, if the surgery is contraindicated, though it is not because you did surgery in the other eye, surgery is the must. Some doctors prefer steroids to see if they can flatten the retina or not. But in my opinion, I would do surgery for this.
Okay, thank you so much. So just to let you know, this is a very good point that you made. For the purposes of this presentation, I just showed this cut, but I did look at all of the other cuts, and he does not have any unroofing or of the cyst or actual full thickness, but he basically has pretty much the same thing that you see here at the very center, at the top of that central foveal area, where there is broad adhesion. Prasan, do you agree? Would you do surgery first, or would you want to inject first, or what would you want to do?
So I do understand that there's a vitreomacular adhesion, retraction at that point, but I would want to give the patient a chance of having an injection first. If there is a tractional component which is not resolving with the injections, then surgery would be a choice for me. But I would definitely give a chance of anti-VEGF injection for the patient.
Okay, so you would do occasional 1 or 2 just to see. You wouldn't do monthly.
Maybe monthly till if I can get it as flattened as possible with the injections, okay, and then try and extend it. But always bear in keeping a watch on the traction, because if there's a traction element, it's not going to resolve with the injection.
Okay, so I will tell you what I would, what I thought of when I first saw this. Until we get the results from Dr. Noura, and then we can move on. So my first, okay, great. But let me just say what I would, so I'll for the sake of disclosure, when I looked at this, keep in mind, I've seen this image 2 weeks after it was taken, and the patient was sent to me to treat the right eye, not the left eye. So look, I just kind of sneaked a peek into the left eye, and when I saw this 2 weeks prior, I was like, my thought process was like Dr. Magdi. I would have probably recommended a vitrectomy with an intravitreal injection intraoperatively. So I would like to go in, remove that traction, and then intraoperatively start the injection. But of course, when I saw that patient, he had already received 1 injection of anti-VEGF by a colleague of mine. And I'll show you that. So, Dr. Noura, can we just get the results of what the audience
Yes.
Can I just add a point, Amar, if you don't mind? If you're planning direct vitrectomy at this point for the patient, wouldn't you risk deroofing that large cyst in the center? Wouldn't it make sense to inject the patient with, say, Ozurdex or any steroid sometime before the surgery so that you flatten it and then you do the surgery? Wouldn't that make sense? Rather than straight away jumping into a surgery and try and re-roof the...
Once you added a comment, let me comment. You said now again, you do injection of anti-VEGF or steroids to see.
If you're planning a surgery.
Not planning a surgery. If you are not planning a surgery. If you're not planning a surgery. Just give me a second. If you are not planning a surgery, which type of injection you prefer? Anti-VEGF or steroids in this case? If you're not planning
first. Anti-VEGF first.
Okay, thank you. That's what
okay, to answer you, Prasan, if you look at this particular OCT, there is a thick, it's not a very
I understand. I
roof.
Totally understand.
So if you could go and just cut here and there, I don't really need to unroof anything. So
yes.
So no, I think this will be easily, hopefully, done without any problems. But I will show you the follow-up of what happened with this case. So, but Dr. Noura, can you give us the percentages?
Yes. First of all, the answer 40%. They selected vitrectomy, followed by 33% with anti-VEGF injections monthly. 13% only selected anti-VEGF injection PRN, and the least selected steroid injection, which was 13% only.
Okay.
So,
all right.
Then
vitrectomy. So most people would do vitrectomy. Okay, so that was my initial thought. So like I said, the patient had already received one injection of anti-VEGF by the time I saw him. And this is the appearance of his OCT on the day I saw him for the right eye. So you can see from this OCT, I'm just going to have to move Dr. Noura's screen off a little bit. Okay, so you can see that there is a significant, actually, improvement, of course, of the edema. The neurosensory detachment is pretty much resolved, but there still is a significant traction on the retina in the foveal area, which is the traction that Dr. Magdi was referring to. The patient was extremely happy with the outcome. He noticed the improvement, obviously. And he was actually scheduled for a second injection of anti-VEGF by his treating doctor. And this was his picture. Hold on 1 second. I'm just going to move you back here, Dr. Noura. All right. So this is the I'm sorry, here. So this is on the day I saw him. This is the day of his second injection, or actually with this, he was decided to have a second injection. So Magdi, would you still do another injection or no with this after you've seen the response? Dr. Majdi?
I'm sorry. Can you hear me now?
Yes.
Because let me speak to the audience. They thought right because vitrectomy is the right choice. Let me comment on the OCT first. The OCT says that the vision is better, yes, because the outer segment is good. We always find a lot of traction on the macula, and the patient is not complaining because he's seeing with the outer segment. But the problem is the traction is increasing. The edema is subsiding, and the PVD is increasing, and it cannot separate, so it's pulling on the center of the macula. Keep injecting of this patient to satisfy him, and because he is already satisfied, this is not fair, in my opinion.
Okay. So just to be clear, this is his presentation. After one injection is like this, but this was 2 weeks after the injection. This is 4 weeks after the injection.
Dr. Barka, he recommended vitrectomy with steroids.
Okay. I honestly don't think that any of the choices is wrong. It's a different way of approaching. Yes, sir.
What is the vision after the injection?
Yes, vision after the injection improved. So his vision pre-injection, I'm telling you, the vision before injection, if you remember, was 2100. Vision after the injection was 2060.
Good.
Remember, he also has a cataract.
Yes.
I think the main improvement was, like Dr. Majdi was saying, is the subretinal fluid has resolved. He still has intraretinal cysts, but the outer retina has flattened, and that's probably what made him gain these few lines.
So if you look at vitreomacular traction staging, this would be somewhere around like a stage 1, right? Stage 1A. So do you do surgeries for stage 1A vitreomacular traction? Is my point.
All right. So here we have a combined process.
Pathology.
We have vitreomacular traction and
this is a combined pathology. Yeah.
Right.
Yes.
So based on that.
So now at this point of time, once the edema resolves, it's more like a vitreomacular traction stage 1. So would you still consider surgery for a patient who got stage 1 vitreomacular traction?
Yes, I would. For
yes,
someone
because
like this,
it's not only stage 1, it's a progressive, because comparing this to the previous picture, he's progressing. Should we say that he will deroof the macula? I don't think we should stay, because if the vision is dropping and the traction is progressing, I think you should interfere. But go ahead, Dr. Ammar, and continue your story.
So the story unfortunately was truncated and ended here because the patient is not showing up. Now we're in July, and his last visit was on the 29th of March. But this is why I wanted to present this case, because it's a bit more complex. Honestly, initially I was very for doing a primary vitrectomy. After I've seen the response, I kind of mellowed down a little bit. Maybe my VR genes were kind of like suppressed by seeing this big improvement in the macular edema. So I don't really disagree with giving 1 or 2 injections to reduce the swelling and maybe go in more controlled and do the vitrectomy. But I don't think that we can resolve this vitreomacular traction without doing a vitrectomy at one point. And that's the last time when I sat down with this patient to talk to him. I basically told him, look, you do need that vitrectomy at one point. But yes, I'm okay with waiting a little bit until your hemorrhage is resolved. Things are quieter in the eye from the vein occlusion part. We all. I don't think that this is the kind of VMT that will actually resolve spontaneously. So to answer your question, Prasan, also VMT, I would typically, if it's pure VMT with mild traction, even if they have cysts, I will give them a couple of months, 2 to 3 months, to basically declare themselves, because studies showed that 50% of them can actually spontaneously resolve. But then if they don't resolve, then I would actually go in and do the vitrectomy.
So there's an excellent paper by Harry Flynn where he looked at the natural progression of vitreomacular traction. And according
let me make another comment, because the audience are hearing us, and I always respect all the other opinions, because we are, brainstorming to get the best result. As you said, Dr. Ammar, you would interfere with surgery in this case, but let me put other eye in consideration. The other eye already developed the macular hole. Is that right?
Correct.
So this is something to put in consideration. Number 2, if you keep injecting and you develop the macular hole, you will be blamed, because 1 or 2 injections with progression of the traction, it means you will never release this traction. So you are pushing the patient to the edge. And if you induce the macular hole and it is not natural macular hole anymore, you will be blamed. And third question to you, you are a surgeon, and I do surgery. Is it easier to do it at this stage, or you wait till the deroofing happens? Which is easier?
Much easier now, of course. And yeah, of course.
Because so it's easier, safer, and you guarantee that there will not be a hole. You can even leave that. You can train the vitreous all around, and you can leave it. Yeah. So it's easier. So you should counsel the patient, tell him everything, but you give us a very good story to start with. Other eye is a macular hole, so probably I will know the fate in this eye. Second thing, I have double pathology, and this is why the posterior hyaloid is strengthened, because vitreomacular traction, you will never see this strong posterior hyaloid. Why? Because there is no cellular element. Here, we have a vein occlusion, cells floating into the vitreous, RBCs, hemorrhage sometimes into the vitreous. It will strengthen more and more this attraction, this adhesion. And as you see, it's a flat adhesion, broad one, more than 1 millimeter. So sooner or later, it will deroof, and the traction will happen, and the hole will happen. This is my opinion.
One of the colleagues, Dr. Ammar, was asking, according to the width of the traction, do you think it's multiple scans will help?
Yes, and that's what we talked about earlier, is that we look at the multiple sections to see how broad the adhesions are, and if there are any cuts that can show a full thickness hole or not. But this is the very central part of the scan, which shows the foveal area, the central foveal area. But typically we will scan everything and look at all of them. But for the case for the purpose of the presentation, I just showed this one.
And this one is broad enough to judge. I mean, we don't need any broader. It's broad enough. Go ahead, Dr. Ammar.
Yes.
So can I move to case number 2, or do you have any questions on case 1?
No, and no questions so far regarding your case.
Okay. Case number 2 is also, I think I'm very happy that Dr. Magdi is with us, because your presentation was so nice. And the case, I think, also will have another discussion with it. So this is a 76-year-old female presented with neovascular AMD in her left eye. Visual acuity is 20/60 with this presentation. I've been following her for years, and she was 20/25, 20/20 in both eyes, pseudophakic, everything is okay. She has hypertension and diabetes. Well, so when she presented with 20/60 in this left eye and this picture, I basically sat down with her and I said, look, you've unfortunately moved into the wet type. We need to start the injections. And I was quite positive with my attitude with her, and she agreed with the treatment to do monthly injections. I usually do a loading of 3 to 4 injections to see how things go. So after her 4th injection, she unfortunately flattened, but developed subretinal fibrosis, and her vision dropped to 2200. So you have someone who was in the active phase at 20/60, and I'm telling her everything is flattening, everything is drying, everything is good, but her vision is actually dropping one visit at a time. Now, this is all okay so far. This is basically her pictures in the right eye and the left eye. The problem really happened when she came. Every time when I see her, I look at her right eye and I ask her, how's your right eye doing? And she tells me it's fine. I'm seeing fine. 20/25, his vision is actually stable, not changing at all. But I scan her every time she comes. This is the left eye, and the other one was the right eye. So I'm going to show you now a video, or like a kind of a series of pictures, starting, if you can see the date here, May of 2019. This is her right eye. Focus on that right now, okay? Forget the left eye, unfortunately, because it's not fibrotic. There's not much we can do. But the right eye in May looked like this. And please look at it, and I can show you this again. So keep looking at the images now. Okay, so this is the last image I have for her, February 2020. I'm going to show you this again one more time if you want to take a look. Now, I'm nervous here. So looking at this right eye and telling her, how are you feeling? And, is there anything, any metamorphopsia, any drop in vision? She goes like, no, I'm fine. I'm very okay. Why are you nervous about my right eye? I was like, because there is a change that I am noticing over the 7 or 8 months. And I convinced her to get a fluorescein angiogram. So here's her fluorescein and ICG. Okay. So I'm going to play it for you also, early to late. And let's see it one more time. This is her, on the left of your screen is the and the other one is the ICG, as you can tell. So nothing that impressive. You agree, everybody? I don't know. So your options right now for treatment. And again, we're going to try and poll the audience and see what they think. But the 3 options, maybe there's a 4th one also, which is observation. Other. You can, suggest something. Anti-VEGF observation versus PDT. So, Dr. Magdi, this, I think, one of your cases that you presented looked similar to this, in my opinion, when I was watching your presentation. What do you think of what you've seen so far? Do you believe that we need to go ahead and start the treatment? I know that you said the zero tolerance as far as subretinal fluid is concerned, but in an eye that has pretty much no symptoms, and the left eye, as you can tell, the patient has been very hesitant, disappointed, but hesitant to try to do anything when she has no symptoms. So what do you think?
I'm glad that you put the OCT back, and let's read the OCT together, me, you, and Dr. Rao. This is
Yes, sir.
already lost the left eye with the disciform scar. And this, look at this eye. This is a 67 years old or 76 years old.
76.
Yes. So this choroid is not natural. This is a thick choroid. And she had a pachychoroid, and she had pigment epitheliopathy and some fluid. In my opinion, I would observe this patient, but it would be very helpful if we do OCTA to find out what is going on down there. But this patient is going back and forth between the polyp. It's probably polypoidal, and it's seen on the ICG. There's tiny polyps down there, and it is not leaking much, but it's a polypoidal choroidal vasculopathy, most probably. So in my opinion, if the vision is okay, the patient is satisfied, I would observe. You are afraid because she lost the left eye. My second choice is, if the patient is complaining, I would do photodynamic therapy, because I never know if the intravitreal injection will work or not, though it works sometimes in these cases, but I don't have any, obstacle if I can observe this patient. Once she starts to complain, I will treat. But my opinion is observation.
Prasan?
As Dr. Majdi said, this looks like a pachychoroid. And if you're not picking up anything there, ideally you should do a OCTA, because sometimes below those RPE elevations, you'll see some new vessels. It's not necessarily you might pick up smaller ones on the ICG, but the OCTA may be a better way to judge whether there's a membrane there. This could be a pachychoroid neovasculopathy, in which it's somewhere in between the stage where before the polyps start. So you have pachychoroid neovasculopathy, and these patients generally have little fluid. They tend to have a good response over a period of time, in the sense the fluid, even if it's there, the vision does not drop drastically. And on the OCT, actually, you can judge on the left side, you could see pachychoroid also, which has been described by Spade. So this patient has pachychoroid neovascularization, and I think you can try anti-VEGF. There's no harm in giving anti-VEGF, and ideally she should do well. The only thing is you have to be careful, in the sense, as Dr. Majdi said, overuse can lead to an RPE atrophy in these patients.
Can I add
So, yes, ma'am.
Yes, regarding as the patient is asymptomatic, and you ask her per se that, do you complain, do you suffer from anything? She said no. I wouldn't touch a patient who is asymptomatic. However, I'll observe this patient, as Dr. Majdi said, and I will provide her with ample grid with close follow-up, and allowing her and explaining that the nature of the disease can be progressive, and then intervention like anti-VEGF, like Dr. Prasan said. But I'll give her like an alarm, or alert her that she may, at the end of the road, she needs anti-VEGF. However, I'll provide her with Muller grid for a weekly checkup at home.
Okay, thank you so much, Dr. Noura. This is exactly what I did. She's a very well-educated, despite her age, but she's very smart and very well-educated lady. And that's basically what we did. But I want to show you the OCTA, since you all wanted an OCTA. We happen to have one. So that is her OCTA. I went back to the May, and she had this OCTA. And this is how it looks in the last visit when we did the angiogram back in Feb. So this is back again in May. February. Yeah. So I think, despite the poor quality of the OCTA, I think there is something there definitely that is brewing. And that could potentially at one point be how I can convince her if we need to do something, or if symptoms start to show. But right now, I am exactly like Dr. Noura is saying, hesitant to touch someone who is effectively monocular, and monocular because of a treatment that we did. Of course, I realized the idea that she could have probably exploded worse and got worse if we didn't treat her and all of that. But in the patient's mind, they were 20/60 and they ended up with 20/200 despite the dryness of their retina. So I think it is reasonable to follow a patient like this and make sure that if she develops any symptoms, we can show her these OCTAs and say, look, there is something potentially getting or growing bigger on your images, and we may need to interfere. And if we interfere, probably, I would say anti-VEGF, maybe just to see how she does with that. We do have access to PDT. We have a PDT at Moorfields, but my experience with PDT is that they don't do very well with these kinds of lesions. They do much better with a classic membrane or purely classic membranes. So I'm glad that you gave me comfort that I'm not really doing something out of the box here. That we're hopefully all on the same page. And again, that goes back again. There's no dispute that there is some fluid there, but despite my eagerness to dry everything that's underneath the retina or inside the retina, but there are some times where we really need to look at the art of medicine and try to see whether the big picture fits with treatment or not.
Gentlemen, do you want to know the results now?
Yes, please, ma'am.
Okay, so half of the attendees, which is 53%, went for anti-VEGF injections, followed by observation, 41%, and then 6%, they selected PDT. PDT,
okay. Yeah, so, again, like I said, the first knee-jerk probably will be reflex is to treat because there's fluid. And fluid worsening, the way I presented it, I'm showing you over the past 10 months how things actually worsen. But I think if you look at the whole thing, it's probably best to observe her, especially that she's asymptomatic. So in the last 5 minutes I have, I think in my time, I'm just going to go over some special situations when we're dealing with patients with macular edema. And sometimes we whether that's that DME or with the AMD. So let's look at this patient. This is also a patient of mine, 74-year-old male, already received about 3 monthly injections of anti-VEGF for neovascular AMD. His last injection was about a month ago, and I got a phone call from his son saying that we're in the emergency room because my dad yesterday had right-sided weakness and wasn't speaking well. So I took him to the emergency room, and now they're telling me he might have an early stroke or a mini stroke. Do I come for the injection tomorrow or not? So my first my first reaction was like, please don't come for the injection. Make sure he's okay, and if he's developing a stroke, we need to keep this in mind. And First thing you feel guilty. Did I really cause this? But we all know that with the age, with the comorbidities that this gentleman has, he is very high risk for TIA anyway. But it is important to know that with patients who develop a transient ischemic attack, to withhold their anti-VEGF therapy and try not to inject them, at least in my opinion, for at least 3 months. In this gentleman, I withheld it for 6 months actually, and in the meantime did 1 session of PDT to try just to make sure that he doesn't really explode significantly, and he did well with that. Now the other situation that we sometimes encounter is diabetic ladies who get pregnant. We all know that pregnancy can either cause the development of diabetes, or if a patient is already diabetic, it can actually exacerbate the disease and cause macular edema. So this lady, 32-year-old type 1 diabetic, presented with bilateral blurry vision, and she's a 22-week pregnant with her second child. Visual acuity was about 20/50 to 20/60 in both eyes. So with edema and NPDR, no proliferation, no neovascularization. In these cases, the recommendations, and we are about to publish, the ESO is about to publish the recommendations of how to manage DME in general. But in these situations, the anti-VEGF therapies are not really recommended. They are considered teratogenic, and despite that, there are no studies that have ever been done to actually see if the pregnancy is going to be premature or end or cause anything. But the anti-VEGF medications are classified as Class C by the FDA, which should not be used in pregnancy. So the recommendations for treating patients with pregnancy, if they have worsening edema, is to treat them with laser therapy and try to delay it until the third trimester, and of course control of the sugar as much as possible in order to avoid any worsening in their vision. This is it for me, and thank you so much for your attention, and we'll move on.
Okay, thank you, Dr. Ammar, for this nice debate between us. We are going to have cases, one with Dr. Prassan, and then with Professor Majdi first, and then we'll end with Dr. Prassan, because we are having a nice, attractive questions to be dealt with you, gentlemen. So, Professor Majdi, your case now? Or are you done with your cases?
Yes, I'm done. I will open share screen right now. Let's see.
There are a couple of questions, Professor Majdi, are waiting for you at the end of the webinar.
Okay, I'm not going away. I'm here. Can you see my screen now?
Not yet, Prof.
Are you sure? I'm trying to share again. Share screen. No, it's not share file. Because I put it in share screen, but it's,
now it's
yes, now it's fine. Yes, I think so. Now you can see it, right?
Yes, Prof.
My talk is not like Dr. Ammar. It's not that I used to do that, but nowadays I'm finishing this quickly. I will show you some cases when diabetic retinopathy and neovascular AMD, when both lesions exist, and sometimes you overlook one of them. In a quick introduction, in one slide, that we can say that age-related macular degeneration and diabetic retinopathy are both of them are major cause of irreversible visual loss. And we used to think that high myopia is not getting diabetic retinopathy, and once the patient get atrophic changes and age-related macular degeneration, they rarely get the diabetic retinopathy, or even if they get it, they don't get the advanced stage. But as we can see on the slide and the color and fluorescein here, we can see huge amount of reticular drusen and age-related macular degeneration and proliferative diabetic retinopathy in the same time. So sometimes both pathologies exist, and we will never expect how aggressive both of them can advance. Sometimes when we look at a patient like this, we had a diabetic retinopathy, all the changes are there, ischemia in the nasal side, the leaking capillaries, and we have tiny lesions here denoting that this patient had something down there. In most of these cases, OCT is quite good enough. I thought this is something leaking down there, but it is not. It's flattened retinal pigment epithelium detachment, and we can see the atrophy of all the outer retinal layers, and OCT is conclusive, and we have to treat this patient as diabetic macular edema, nothing else. But when I had a patient like this, who is a 69-year-old, and he's proliferative diabetic retinopathy, NVEs on fluorescein angiography. By the way, I scanned his fluorescein because he presented to me with this, and I scanned his OCT, as you can see on the left side, cystoid edema, multiple hard exudates, and he had multiple neovascularization in the central area, as we can see. So this is the whole picture, and we can see that this patient had definite diabetic retinopathy with cystoid macular edema. But the point is, this patient was already treated, and he had his OCT after the treatment, and he said, I'm not getting better. He had one injection and two injections, and then when he presented to me, I started to look at him, and after 3 months, the injection he had, I looked at this, and I did another OCT, and I found this. So probably this was missed at the first presentation. This is a sub-RPE lesion with the overlying fluid, which easily overlooked because of the diabetic macular edema. This picture is improving, as we can see here. Again, we missed that lesion. So if we can see that the central foveal thickness is involved, and I'm pointing with the red arrow to something leaking in here, which we can think sometimes it's a NVE, but it is not. It's subretinal, and it's leaking NVD, and we can see by OCT angiography pointing in this area. We can see the cube here. It's nasal and superior to the fovea, and we can see a very florid choroidal neovascular membrane. So we have to follow up injecting this patient. We don't extend. We have to dry the macula completely because this is not a diabetic macular edema. This is combined diabetic macular edema and CMV, and we have to dry it as much as we can. And we all know that this patient might end up with a geographic atrophy and also, disorganized outer retinal and inner retinal layers, as we can see it. Is disorganization in here because of the ischemia, and there is hyperreflectivity of the retinal pigment epithelium, disruption of the photoreceptor. But we should keep injecting this patient until they are completely dry because we have combined pathology and it's easy to miss the second pathology. Another patient, 62 years old, presented with diabetes in 10 years, and she had right diminution of vision is 636, and focal macular edema in the right eye, as you can see, with a foveal cyst. And the fundus, there is multiple changes of the non-proliferative diabetic retinopathy. I will show you the fluorescein in a minute. And the OCT, we can see the foveal cyst, which is a center involving cystoid macular edema. And his right and left eye, always remember to look at the left eye. The left eye had minimal diabetic changes, only few micronerisms, but we have RPE changes. We have RPE atrophy, we have RPE detachment, focal hotspots. And on the right side, we can see the focal RPE hyperplasia, the leaking microaneurysm, and the cyst. And we always go and think deep in these cases. Look at the outer retina. This is the RPE hyperplasia, the line passing through, and this is the cyst. But look at the retinal pigment epithelium. This is a double layer sign where the RPE is separated from the Brooks membrane, and anti-VEGF will work, but 1 or 2 injections will not do the job because this is not a diabetic macular edema. This is a pachychoroid with new vasculopathy. So in diabetic macular edema, I always count on PRN, injecting and following up the patient. But here, what to do to make sure that this patient is not only diabetic, as we said, this is a pachychoroid with multiple lesions, and we can see the flat and irregular RP detachment. And OCTA is conclusive in these cases. I'm showing you the OCTA at the level of superficial AMD plexus. There is ischemia, definite ischemia, which contribute in the visual impairment. There is enlarged phase at the level of superficial AMD plexus. But if we look at the outer retina, this is the clue. We have a neovascular front, active one, which probably is implicated in macular edema. So we have to treat this patient as a combined one, should give a loading dose. We should, follow him up as a neovascular AMD and diabetic macular edema. This is after 3 injections, and she's getting dry, vision 612. We got rid of the cyst, but still we have this elevated retinal pigment epithelium, and we should treat this patient as pachychoroid neovasculopathy plus diabetic retinopathy. And we should never lose follow-up of this patient because we all know that the 2nd and 3rd year in diabetic patient, we decrease the injection, but in neovascular AMD or the pachychoroid neovasculopathy, it's a non-forgiving disease, and we have to keep following. And this is from the literature. Everybody is speaking about that age-related macular degeneration and diabetes are significantly increased incidence of both lesions together. And many articles about outcome of intravitreal injection. It's the same treatment, but at least you consider that this patient are treated mainly as age-related or pachychoroid neovasculopathy plus the diabetes, because we all know that these are completely different from each other in the regimen of treatment. So my take-home message is combined pathology are not rare entity. You have to think of double lesion, and diabetic macular edema can be misdiagnosed in cases of dry AMD, as we have seen. Sometimes we look at the patient dry AMD and we think that he will never get a diabetic macular edema, but they can get that. And multimodal imaging can have to use everything, fluorescein, OCT, and OCTA to reach the final diagnosis. And anti-VEGF, of course, is the treatment modality of choice. And higher level of VEGFs are present in this patient because they are getting VEGF from the diabetic side and the neovascular side. So the higher consumption of the VEGF, it means that we will need more and more injection to dry this patient up. Thank you so much for your listening.
Thank you so much, Professor Majdi. Now our last case with Dr. Prasan. Go ahead, Dr. Prasan, if you can share the key.
Can you see my slides?
Yes, doctor. Yes, we can see.
Okay. So this is a case of a 60-year-old lady who presented to me about 7 years back. So she complained of reduced vision in the right eye more than left eye since about 2 months. She had no floaters, no flashes, no photophobia, no redness, no pain. She's diabetic hypertensive. The right eye vision is 660 and the left eye is 6 by 18. Pupils are normal, anti-segment is normal, IOP is normal, blood pressure is 140/90. And this is the fundus picture of the right eye. Apologies for the poor quality because these are old images. So this is how the disc looks like. Disc is normal. She's got some swelling in the macular area. She's got tortuous vessels going all around. Some telangiectasia noted, not so clearly. Some few microaneurysms in the inferior quadrant. This is the left eye image. Again, she's got extensive tortuosity of the vessels. Disc looks normal, macular thickening, some hemorrhages, microaneurysms noted here. This is how our OCT looked like. So the OCT showed a large area of subretinal fluid. There was some diffuse retinal thickening with some cystic changes in the center. Similar kind of picture in the left eye with subretinal fluid, some cystic changes, some diffuse retinal thickening in the paramacular area. So my differentials were, one is an impending CRVO, could be anemic, could be hypertensive, diabetic, considering a history. We thought of hypercoagulability syndromes, some hyperviscosity syndromes, and we also suggested the patient to undergo an angiogram. So these are angiography images. If you look at the angiography image, the disc looks pretty okay. You have some deeper choroidal changes here. The vessels are actually quite tortuous. This is again does not show much of change here in terms of the retinal vasculature, except for gross tortuosity and dilatation. And these are the late phases. So if you look at the right eye, you don't see classic leaks here in the central part of the eye. Some deep retinal staining is there in both the eyes. So having thought of this didn't look classically as a case of either a diabetic retinopathy or central retinal vein occlusion. I decided to do some basic investigation. We did a hemoglobin test for her. Her hemoglobin was 6.2. The ESR was 160, which is quite high. And the pathologist reported that she had these Rollet formations in the peripheral smear, indicating also she had normochromic normocytic anemia. So this patient was then referred to our internist, and if you look at the causes of Rollet formation, you have infections, hyperviscosity syndromes, connective tissue disorder, diabetes, anemia, which this patient had, or hypovolemia. She was further investigated. They did a HB electrophoresis. They formed these M bands in the gamma range, and then they did a bone marrow smear as well, which clearly demonstrated the presence of plasma cells. She had bone marrow imprints which are suggestive of a melanoma. A myeloma. And a bone marrow biopsy was done, and this again showed infiltrates of cells with oval nuclei, clock phase, chromatin, which all suggestive of plasma cells. Again, indicative of multiple myeloma or some sort of a gammopathy present. Now, to differentiate between multiple myeloma and the other condition, which is Waldenstrom's macroglobulinemia, you need to do a urine test, which is for Ben-Jones proteins, and also do an X-ray spine and sacroiliac joint. This was all done by the internist, and there were no lytic lesions seen, and eventually a diagnosis of Waldenstrom's macroglobulinemia was made by the internist. So this patient actually had this condition, considering she had the presence of IgM monoclonal paraproteins in her serum, and as well as malignant lymphoplasmacytic cells on bone marrow aspirate. So just as a discussion, gammopathies are conditions where you have elevated serum immunoglobulin levels. There are two types, polyclonal and monoclonal. Polyclonal is where all the major immunoglobulin classes are raised, and monoclonal gammopathies, you have predominantly a single IgG, usually an IgM protein, which is raised. The ocular manifestations of gammopathies can either be related because direct deposition or infiltration of the immunoglobulin into the ocular structures. So they go and stick themselves to either the cornea, pastula, and all the layers of the retina, or it can be an indirect manifestation of serum hyperviscosity condition. So this is classically known as dysproteinemic fundus. Patients have optic disc swelling. They can have retinal capillary microaneurysms, cotton wool spots, retinal hemorrhages, dilated retinal veins, all similar to patients with diabetic retinopathy or central retinal vein occlusion. Why is it important to differentiate this condition from diabetic retinopathy or vein occlusion? Is because the macular edema here does not respond to anti-VEGF or steroid injections. So a brief about Waldenstrom's macroglobulinemia. It was described by von Walderson. It's a malignant lymphoproliferative B-cell lymphoma characterized by overproduction of monoclonal IgG-M. These IgG-M macromolecules can adhere to various blood structures, and that's the reason you get Role formation in the peripheral smear. And it also adheres to the blood cells, causing anemia, leukopenia, and thrombocytopenia. These patients will have systemic weakness, anorexia, peripheral neuropathy, weight loss, and fever. Predominant symptom is weakness from the abnormality which they have. A classic key thing to remember is most of these patients are bilateral, or some patients can even have unilateral serous macular detachments, and they have absence of angiographic leakage on fluorescein angiogram. And this is because there's exudation from the retina and the choroidal vasculature, which is not the primary cause, which is basically a deposition of the IgM gammopathy depositing in the subretinal space. So the term is coined as silent macula, which is a hallmark of immunogammopathy-induced serous macular detachment. The mechanism is unknown, but usually it is said that the IgM will get deposited even in the retina, and eventually you have breakdown of the outer retinal barrier, and then the deposition from the retina goes into the subretinal space. Or it can deposit into the choroid and cause a choroidal pathology and leak into the choroid. The classic OCT finding is a stalagmite-stalactite OCT pattern. So this is, if you see any of this, one of the first things you need to think of is gammopathy. So please don't treat these patients with injections because they are not going to have any response. You can get hyperreflective foci on the undersurface, which can be a precursor of these stalactites and stalagmite appearance. Also, focal disruption in the outer retina within the detachment. And there can be focal defects which eventually track and cause the IgM to trickle into the subretinal space. The treatment is primarily systemic. So these patients require plasmapheresis or blood transfusion, systemic chemotherapy, which may not improve the vision, or even oral rituximab has been tried. As I mentioned, anti-VEGF in any form doesn't work because they have very poor results. And wide field angiogram is essential to look for non-perfusion in the periphery. Because if that's there, then you can probably consider doing a PRP if there's associated neovascularization. Visual prognosis is very guarded because we have chronicity of fluid and the sequestration of IgM in the subretinal space. So that's my case. Thank you for your kind attention.
Thank you, Dr. Prasann Rao. Thank you so much, doctors, for your great presentation. I'm just informing the audience that there will be a 3-hour CME accredited, and you can find the certificate after answering the questions in the link. You can find it whether you are using the desktop or the mobile, and just click on the link button, and at the end of, even if during the discussion of the questions that you have submitted, I'm going to share with you the link also. So Dr. Prasann, there's a question since you began your talk from Dr. Mandeep Lamba. He said that, do you think that OCTA is sufficient to differentiate between actual capillary dropout and pseudo disturbance of phase and cystic type of DME?
So actually, this is a very good question from Mandeep. The thought was in OCTA, when you look at cyst, there are two schools of thought. When you, in the presence of a cyst, you generally don't see capillaries. And one of the schools of thought is that once these cysts are formed, they displace the capillaries to the side. And sometimes they may not be visible then on OCTA. The second school of thought, which generally is predominantly followed, is when you have cysts here, these cysts actually occur in the area of capillary dropouts, as I mentioned in my presentation. So I think OCTA is a good way to judge whether there can be dropout in these areas. And currently, that's our standard of care in terms of diagnosing. Maybe we might have better modes of doing OCTA, better technology, which can look at even capillaries which have a very flow, which are being missed by our current standard OCTA machine.
Okay, and the questions now to the panelists. How to differentiate as long as we are talking about cysts? Dr. Ahmed al-Barqi, he questioned how to differentiate between degenerative and active cysts with different diagnostic tools. So whoever wants to answer this question.
May I?
Yes, sure.
Hello?
Yeah.
Hello?
Can you hear me?
Dr. Prasan is, I would answer that question. It's a very important point to differentiate between degenerative cyst and, cystoid edema, because always combine the fluorescein with the OCT. In the cystoid edema, you will find the leaking vessels in the retina, like diabetic macular edema. We used to count only on fluorescein angiography 20 years ago in vascular AMD, and we were, is it a leak? Is it a stain? But as long as you have no leakage from any vessels in the retina, it's a degenerative cyst, if you compare that with the OCT. Again, look at the whole retina. I mean, you shouldn't look at one line scan. Look at the multiple line scans. There is no degenerative cyst in all line scans, but you can find edema in most of the line scans. Third thing, if you are seeing the patient from the beginning, the initial fluorescein and OCT combined together, you would be able to differentiate which is cyst degenerative and which is, vascular one due to leakage from the vessels. And I always count neovascular AMD when I have this kind of cyst at the end stage of the disease. I do OCTA to find out if the membrane is still active or not, because sometimes it's very crucial to differentiate. But if you have a proof from OCTA that the neovascular membrane is not active anymore, it's a dead tree, make sure that these cysts are degenerative ones and it is not an active one.
Can I add one more point?
Sure.
So when you have fluid within the retina, the volume of the retina increases. So if you have a leaking cyst or a cyst which is because of a leak, you will have increase in the thickness of the retina. If you have degenerative cyst, usually it's a sign of atrophy. So these patients generally either have a normal retinal thickness or they have a slightly thinner retina. So that could also be one of the ways to differentiate whether these are leaking cysts or they are degenerative cysts.
Can I add one more thing?
Over a period of long time.
Sure.
I agree with everything that was mentioned. And along the same lines that Prasan just described, the volume of the retina, I think also degenerative cysts typically look like they're flatter as opposed to leaky cysts that look full. So if you see a vacuum area that looks like potentially fluid, but it doesn't really look like a cyst, it looks more like a squished cyst, then that's typically a degenerative area. But again, fluorescein angiogram, I think, is the gold standard.
Okay, and regarding to the pachychoroid vasculopathy as a part of spectrum of CMV, is it a part of spectrum CMV or separate entity? Dr. Majdi, the question is to you.
It's a CNV anyhow, it's a CNV, but we used to classify CNV in young age without drusen, without anything, like idiopathic CNV. Now we call it pachychoroid because we always look there and find the pachychoroid. Second thing, it's a spectrum of CSC because chronic CSC in young patients might turn up with pachychoroid and, pachychoroid pigment epitheliopathy and neovasculopathy. So it's a spectrum of CSC with complicated with CNV. So again, it's a type of CNV usually happen in young age, but again, it is not in young age. We can find it 60s, 70s, as Dr. Ammar showed us his case, 76 with pachychoroid. So we are supposed to find very thin choroid in 70s and 80s. He had a very thick choroid and started to leak under the retina. So it is not age related. It is always there when the choroid is thick, and we will never know why the choroid is thick in this patient and why is not, because we have young and old with thick choroid. So it's a spectrum of CNV.
Okay, there are a couple of questions, Dr. Majdi, for you. Are you ready to receive some?
I'm ready.
Yeah, from our dear colleague, Dr. Najla Hassan, she said that for diabetic retinopathy, how can I differentiate PCV associated with CNV on OCTA? Is there any special clue?
Say that again, PCV?
Yeah, and how can I differentiate PCV associated with CNV by OCTA? Is there any special clue?
It's better by the OCT. I mean, OCTA will tell you if there's a membrane down there or not, but the OCT is the clue here. The structural OCT, we can see the elevated retinal pigment if it's a flat and irregular, the pachychoroid, and then sometimes there is no CNV. Sometimes it's only pachychoroid pigment epitheliopathy. We find the elevated retinal pigment epithelium with underlying thick choroid, but there is no CNV. So combining the structural OCT with the OCTA will give us a clue. It is only pachychoroid pigment epitheliopathy, or it's a pachychoroid pigment epitheliopathy with neovasculopathy. So we have to combine both of them. Otherwise, we will never know if there's an active membrane or not. Second thing, the structural OCT is very good in differentiating the double layer sign. If you find that the retinal pigment epithelium is separated from the RPE, this is another diagnostic sign that there is something down there. And the fluid overlying, you will never know if it's due to the diabetes or the CNV unless you do OCTA.
Okay. And from Dr. Mahmoud Mustafa, the question for you, Prof. What is the extension of injection at maximum duration?
The maximum extension.
Yeah, treat and extend. What's
the
longest?
Actually, the maximum we get is 16 weeks, which is 4 months. And let me tell you the other thing. Not all the drugs, because we are not speaking commercially, not all the drugs can extend to 16 weeks, because in Egypt, I'm still using Avastin, by the way, and it cannot be extended to this amount because of the lifespan. And that's why all the companies, and we all know that it's coming to the market, the brolucizumab, because we need to extend. So if the molecule will not allow you to extend, you will never be able to extend that amount. So 16 weeks is the maximum I could get, but I think with more and more coming in the pipeline, I think we can extend more in the future. But the maximum I could get is 16 weeks.
Since you are dealing with Avastin, there was a question that has been submitted earlier. Since we are not using Avastin, so you are the best person to answer this question. Dr. Abba Hydra, he said that he has a case with diabetic macular edema that received over 4 intravitreal Avastin with no observable improvement. In your experience, doctor, what is the recommended management strategy in these categories of patients with chronic diabetic macular edema unresponsive to Avastin? And when should one draw the line after how many injections in terms of ineffective? So when can we say that we have to stop because since it is not effective?
This is another good question. Avastin, we start in, I mean, I'm never satisfied with the loading dose in diabetic macular edema, but I do 3 injections. Some of the literature say continue to the 6th injection, because a lot of studies now saying that if they are not responding in the first 3, give them a chance up to 6 injections. But this 6th injection didn't do anything. They said non-responder. They categorized this as non-responder. I have to switch to another anti-VEGF. But sometimes people fed up after the 3 injection because the patient is not seeing any benefit. So it's again eligible to switch after 3 injection, but give him some time. If there is 10 to 20% response, it is not a non-responder. It's a responder, but it's a poor one. So continue injection. But if after 3 or 4 injection, no response at all, or even the macular edema is increasing, you have to switch to another anti-VEGF.
Okay. Dear colleague, Dr. Mohammed Al-Amri, he asks a question about the second case that you presented, which was, where's the question went? Yeah, that he said, how can look for macular atrophy in case of treat and extend, like the second case you presented?
This is from Dr. Mohammed Al-Amri.
Yes.
I'm glad that he has the time to share and ask, because Amri is busy all the time. I've seen him twice every day, 2 or 3 times, sending messages, doing webinars, doing everything. I'm very glad that he's here and he's attending our webinar. Thank you, Dr. Mohammed. Thank you so much for giving us 10 minutes of your time. Thank you. Anyhow, he's a dear friend, by the way. I'm teasing him. Geographic atrophy, as I said, sometimes the recent publication about the geographic atrophy, they said that 50% of patients who had RAP will develop geographic atrophy at the end. Another very good diagnostic sign is the reticular pseudodrusen. Sometimes reticular pseudodrusen is different from drusen because it's above the retinal pigment epithelium. Once you find any of this, you might expect a rapid progression to geographic atrophy. But how can you avoid this? That's why I'm saying treat and extend is the best, because you avoid unnecessary injection. Once you find the macula is dry, the vision is the maximum you get, 6/9 is the maximum. If I inject 3 loading dose and the patient is completely dry and he's 6/9, for instance, this is his maximum vision, and I injected once more and I extended. So if the fluid comes back again and the vision is 6/9 and minimal subretinal fluid, I will extend. But if the intraretinal fluid comes back with diminution of vision, I will not extend. So to avoid, to treat and to extend as much as you can to avoid unnecessary injection, and look at the bad prognostic sign, reticular pseudodrusen, and as I said, REP. But again, geographic atrophy can happen of any type of neovascular AMD. I'm also having a bad prognostic sign with the multiple retinal pigment epithelium detachment. The multiple retinal pigment epithelium detachment, especially with those huge one with fluid underneath, once they flat, they get atrophy. Once they flat, they get atrophy. So you get a geographic atrophy later on. But sometimes it's inevitable to end up with geographic atrophy. But as I said, studies say unnecessary injections, keep injecting PRN or keep injecting monthly dose. It's another crucial thing you have to look for, and look at the bad prognostic sign at the beginning. Thank you, Dr. Mohammed, again for the question. Thank you so much.
Now the questions for the panelists, whoever would like to have to give a break for Dr. Majdi, and whoever wants to answer that. But mind that the link for audience, the link for certificate, it's already there, and I have shared with you the link also to everyone in your chat box. The last 4 questions that our doctor again, Najah Hassan, she said that it is very rare to see both diabetic retinopathy with CNVM. I just saw 3 cases in my life. Any pathological explanation regarding this combined pathologies, DR with CNVM? Whoever wants to answer?
No, first, I'll answer, but I don't think there's a known explanation as to why. But we do know that there is a neovascular process that's taking place in both diseases, whether AMD or diabetes. In general, it is a rare disease. I agree. I've seen a few cases in my life, but it's not something that there was at one point the theory that it is protective in a way, that if you have diabetes, you don't have AMD, or vice versa. But as Dr. Majdi presented very eloquently, there are those cases. They do exist. Why does it really happen? I don't really know, but I would say the cases that I've seen were somewhat related to previous laser treatments that were done in the macula, probably, that may have created some cracks in the Brooks membrane. And if you have the drusen, if you have the predisposing factors to have any vascularization, then that could be a reason.
Okay, doctor. Thank you for the question, answering the question. How many, as you are also on board with us, how to manage Irvine gas edema?
Irvine gas, as we all know, is edema that happens after phaco. Typically, if it's complicated, although sometimes it does happen with uncomplicated phaco also. Usually in my, I think the confusion happens sometimes when you have Irvine gas in a diabetic patient. Is this due to the is this the ME, or is this due to is it Irvine gas? Obviously, the OCT wouldn't be that helpful, but it can sometimes be characteristic. Fluorescein angiography would be quite helpful to see if there's any staining in the disc, which is characteristic of Irvine gas. I typically treat it topically. Start with topical treatment with steroids and non-steroidals for a few weeks, and monitor them after 3 weeks or 4 weeks. If there is no improvement, then I will move to sub-tenon or regional injections of steroids. And then finally, if there's a poor response, then I would do intraocular steroids.
Okay. It's an excellent answer. I'll do the same, honestly. I'll try the topical first, the NSAIDs. And do you see that it is common here, Dr. Ammar?
I have not been seeing a lot of Irvine gas. I had a lady that just came to mind now that you mentioned her. She was in her late 60s probably, I did bilateral cataracts for her. She's not diabetic, uncomplicated, in the bag, no vitreous loss, but she developed CME in the first eye and CME, or systemic macular edema, Irvine gas in the other eye. So there must be some sort of predisposition to developing this condition. I have not seen it as much.
Mm-hmm. Yeah.
May I add something, Dr. Noura?
Sure. Go ahead, Prof.
I do see a lot of cases in Egypt. I don't know why, but probably we have, a lot of phaco done and a lot of complicated cases is done. So as you said, it's very rare in uncomplicated cases, though it's there. But in complicated cases, we have to put in mind. I've seen a case of Irving gas after 1 year of the surgery, and it was extra cap because something went wrong and there was a hole in the posterior capsule, though the anterior vitrectomy was done and everything. But make sure that Irving gas can even happen after years of the operation. I start, as you all said, with a topical, but I have something to add. In my country, sometimes I try posterior subtenon steroids, and it works very fine in some cases before start injecting intravitreal. And last thing, look always at the complication. If you have problem like a vitreous incarcerated in the wound or vitreous was not vitrectomized, this is a cause of chronic Irving gas. It will never vanish. So you have to interfere sometimes in these cases because the vitreous is the cause. It is not tracting in the macula, it's tracting on the ciliary body. It will cause chronic posterior uveitis, mild uveitis, but it will keep pooling the fluid inside the macula every now and then.
Since you are talking about pooling, the questions are pooling now to you, Doctor. Dr. Majdi. Dr. Mahmoud Mustafa Abul Aita, he said that Dr. Majdi, do you think that any VMT is contraindication for injection?
I have a lecture once I presented what's called vitreomacular interface abnormalis. We have to read this paper. It's a classification. There is a vitreomacular adhesion and there is a vitreomacular traction. Vitreomacular adhesion can happen while the vitreous is separating without any pathology, like the idiopathic vitreomacular traction syndrome. So once you find vitreomacular separation, foveal adhesion, as Dr. Rao said, we don't treat sometimes at the beginning because the vision is not affected. But if there is a pathology like diabetes or any other pathology inside the eye, like vein occlusion, and there is strong adhesion and broad adhesion between the vitreous and the macula, surgery is a must, because keep injecting or sometimes even injecting without doing OCT, mind it up with the macular hole. So tiny vitreomacular adhesion in a very small spot in the fovea, and sometimes I call it vitrofoveal adhesion. Even in diabetics, I do inject. But if it's an adhesion with a very strength posterior hyaloid, hyperreflective band, broad adhesion to the center of the macula, this is contraindication in my account for injection.
So can we allow that Dr. Prasan answer the last two questions because it's almost 11:05.
Sure.
Prasan, are you around?
Yeah.
Okay.
Yeah, not sleeping.
Dr. Ahmed, he raised a question. How common is that for subretinal fibrosis, a fast subretinal fibrosis following only 4 injections? Is that common, or I think he injected like 4 injections and subretinal fibrosis got to a patient?
I don't think so. I think it's pretty rare that you see early, unless the patient has come in a very late stage, there's already a lot of exudation and you have subretinal fluid and already some signs of scarring, because with 4 injections getting subretinal fibrosis is very rare. I haven't had experience with patients with AMD who had 4 injections and scarring, but yes, over a period of time, they do tend to get macular atrophy, but we really don't know why does this macular atrophy occur. A lot of it is attributed to the anti-VEGF injections. A lot of it is maybe a natural process of the AMD itself, where the RP keeps getting atrophied and you have loss of capillaries as a natural process. But 4 injections causing subretinal fibrosis, to me, it's rare. I think it's probably Dr. Ammar's case was just one off.
Can I comment on that, Dr. Noura? In all the injections with AMD that I have done in the past, probably since I moved to the UAE 8 years ago, I had only 2. One I presented tonight, and there's another guy. That after only 4 or 5 injections, so they came in not late like Prasan is saying, that I understand, but I've showed you the OCT of this lady. She came in right away when she had a change in the vision, and we started her treatment. It was really a surprise, a bad surprise to me, but it is a rare thing to happen. Typically, you would expect them to actually not develop that quickly.
Can I just add a comment? Was it subretinal fibrosis or macular atrophy? Because I thought the RP had got totally atrophy, sort of thinned out in the macular area.
Subretinal fibrosis.
They are speaking about fibrosis, yes.
Fibrosis.
Yeah.
And can I add a little more? I mean, just a small comment about that.
Yes, please.
As Dr. Omar said, it's very rare, but I've seen a couple of cases, but always look at that with PCV. Sometimes they get massive hemorrhage. It's inevitable to get fibrosis, massive subretinal hemorrhage. And second thing, as he said, it's not expected sometimes after 4 injection, but look at the presentation time. If you have a SHRIM, which is a subretinal hyperelectric material, if you have massive hemorrhage or you have even minimal hemorrhage, but it's in the macular area, sometimes these are triggered for subretinal fibrosis, quick ones. But as he said, I've never seen a case coming early and end up with subretinal fibrosis. It's very, very unusual. But sometimes when they present even early, but with, aggressive manifestation, SHRIM, hemorrhage, massive exudation, we will end up with fibrosis sometimes in these cases, but it is not that quite, frequent we see.
Okay, the final question for you all panelists regarding what do you think about a quick answer. I know it's a broad topic regarding the central serous chororetinopathy, as they ask what is the best treatment. But we have a case here from Dr. Khalid Hashim, and this is, I promise, the last case and last question. What is the best treatment for a young patient with bilateral huge CSR? And his vision is 6/12 in both eyes.
Observation. Steroid use. Rule out the steroid use or any other.
We need to ask more questions. We can't really just say one answer.
Yeah.
But
in my answer, I don't observe these patients anymore. If I have a bilateral CSC, I start with spironolactone or epinephrine, because sometimes I don't wait for the natural process. If he had a bilateral, this is very unusual, but huge bilateral. So as Dr. Rao said, if he's not on steroid or he didn't have any steroid, because this is the trigger, I will start from the first week by spironolactone or epinephrine.
In fact, if it's a bilateral presentation, I would be worried about VKH or something like that more than CSR.
You are counting on the proper diagnosis. He said CSC. He didn't say anything. He didn't say anything.
The other thing is, this part of the world, we do see a lot of patients having bilateral CSC. Quite a lot of them are into gymming, and they use some sort of anabolic steroids.
Yes.
Which could also be one of the triggering features. You
and they deny it, by the way.
Things.
And they deny
it. Absolutely.
They never say that they are in steroids.
Absolutely.
Yeah. So thank you so much. I think it was a very nice interactive talk and very interesting aspects of tackling the A to Z, as we titled the webinar, A to Z in macular edema. 3 of you did magnificent presentations, cases, and even with the debates. Thank you so much, Dr. Prasan Rao. Thank you so much, Professor Majdi, and hope to see you. Dr. Ammar, thank you so much. Can't thank you enough of your time. I know it's late, 11:11. Thank you so much, Novartis, Hazar, and Shuruk per se. Thank you, our attendees, and I would like to let you know that this webinar it will be loaded in our series of webinar in our EZO website. Looking forward meeting you in the upcoming webinars, and also can't wait to meet you in person. Till then, a nice weekend and stay safe.
Thank you.
Thank you so much, Dr. Noura, for the coordination and moderation. always smiling, even with bad questions, even with everybody's getting more and more time. Thank you so much. Thank you so much. You adjusted with us for 2.5 hours. Thank you, Nuvart, and thanks, Dr. Rao and Dr. Ammar. I'm really appreciating, with you and Dr. Noura, we had this nice webinar, and I feel like we did a very good job in discussing and brainstorming and, discussing cases. This is what we really should do every now and then. Thank you so much, everybody.
Thank you, Dr. Thank you so much, everybody.
Thank you, everyone. Thank you, Dr. Noura. Thanks a lot. Bye-bye. Good night. Stay